Hi everyone, my name is Ashley Sun. I'm a research data analyst at Aspire in the surgery department, and today I'll be presenting our project on comparing the performance of nurse-extracted versus machine-extracted risk adjustment variables for the VA CABG only 30-day mortality model. The Veterans Affairs Surgical Quality Improvement Program, also known as FASQIP, provides risk-adjusted data that is essential for improving cardiac surgical outcomes. Surgical quality nurses, also known as SQNs, collect over 180 variables related to cardiac surgeries and utilize 15 key variables to develop a 30-day mortality model for CABG procedures. Facilities with high observed to expected ratios are targeted for quality improvement efforts. Our study compares the OE ratios from the CABG model using SQN extracted variables against two models, one with 14 machine extracted variables and another with 7 highest performing machine extracted variables. We developed methods using techniques such as data manipulation and rule-based text extraction to machine extract 14 of the 15 risk adjustment variables from structured and unstructured data in the VA corporate data warehouse, excluding functional status, which we could not extract with adequate accuracy. Our analysis focused on cardiac cases from fiscal years 2018 to 2021 across 154 facilities. We compared facility-level outlier status defined as an observed to expected ratio greater than 1 among 3 models. 1, all SQN extracted variables, 2, 14 machine extracted variables, and 1 SQN extracted variable, which we call the machine extracted model, and 3, 7 high-performing machine extracted variables, and 8 SQN extracted variables, which we call the partial machine extracted model. The high-performing variables were defined based on the interclass correlation of 0.4 or higher, or an F1 score of 0.7 or above compared to the gold standard of VASCO SQN extracted data. As shown in Figure 1, which illustrates the distribution of outlier classification across the 154 fiscal year facilities analyzed, we found that 122, 79.2%, were not classified as outliers by any method. Only one facility, 0.6%, was identified as outlier based solely on the nurse extracted data, and another two, 1.3%, based on the full machine extracted method. One facility, 0.6%, was an outlier by both the nurse extracted and full machine extracted data, while 7 facilities, 4.5%, were outliers using nurse extracted and partial machine extracted methods. A total of 21 facilities, 13.6%, were classified as outliers by all 3 methods. Figure 2 presents an OE ratio for SQN extracted data, the machine extracted variables, and the partial machine extracted model for fiscal year 2018. This data highlights the facility-level OE ratios with error bars indicating 95% confidence intervals. The disparities in outlier classifications are also marked on this chart, with orange asterisks denoting discordant outlier statuses between SQN extracted method and machine extracted method, and blue asterisks indicating discrepancies with partial machine extracted method. In this particular fiscal year, there were no discrepancies with the partial machine extracted method and SQN method. In conclusion, while SQN extracted data are viewed as the gold standard for national surgical quality improvement programs, our findings indicate that machine extracted variables can provide comparable performance. Full automation achieved 93.5% congruence with the SQN extracted data, while partial automation demonstrated a 98.7% congruence. These results suggest that machine extracted variables could serve as a viable alternative, enhancing efficiency without significantly compromising accuracy. Looking ahead, automating the data collection process for the variables meeting acceptable accuracy standards has the potential to streamline efforts, reduce resource burdens, and enhance data consistency. This implementation could benefit both FASTWIP and local facility quality improvement initiatives by facilitating timely data analysis and informed decision-making. Thank you.